All right, everyone, it's really great to see you on this last call. It's already June 10th, which is very exciting. We've been going through our champion program for the last maybe 3 months, and I'm really proud of you. I know some of you kind of started and depending on your schedule are able to join from time to time, but it's really encouraging to be at this stage. We've gone through 12 different, today will be the 12th topic in kidney supportive care, and I'm really proud of you guys. I know some of you might be listening to this as a recording afterwards, but this is definitely an area of great need, and we are really excited at AHN to be able to work with you as we kind of pursue more holistic care for our patients. So today is our last day of the 12-module course. You'll be the first people in Kenya and really East Africa, I guess, to have gone through, I know some of you are calling in from Rwanda and Tanzania, to have gone through a very dedicated course to palliative care and supportive care for patients with kidney failure. So really, really excited to have been able to work with you all, and also excited for what kind of lies ahead. So I'll share my screen, but today we are ending on a very interesting note. We are doing ethics. If some of you had a chance to call into the fireside chat on Thursday last week, Dr. Nafula, Esther Nafula from Kenya, brought us through her perspective on ethics. So we're going to continue the conversation. It is sometimes a bit heavy to talk about ethics and ethical dilemmas, but I think this is something that we actually face fairly often. So I'm really keen to have a good discussion with you all today. And we'll do the teaching for about half an hour, and then I'm going to leave quite a bit of time for discussion because I want to share a little bit about what the next few months will look like, as well as get some feedback from you all just in terms of the course and the modules. All right, so my name is Erin. I'm a palliative care nurse and the supportive and palliative care lead for AHN, and I'm really excited to be with you all today. So we're going to be covering ethical and legal considerations related to kidney supportive care. And I know that we at AHN have people working in several different countries, so please do bear that in mind, especially when it comes to legal issues. This will be general information, so this isn't specific to your country. I'm not a legal specialist, but I think it's important for us to consider some of these topics as we support people with serious illness and chronic conditions, because it can get complicated. So we as a healthcare provider can continue to support and encourage our patients in this area as well. If you want to introduce yourself in the chat, I think most of us know each other, but if you haven't been on the call in a while, maybe you can just put your name and then where you're working, which clinic you're in, and maybe which country. That'll be great. So this is our last in the 12 modules of our kidney supportive care program. We started this back in, I guess, March, and have slowly been going through the topics of symptom management. What is kidney supportive care? We talked about pain management as well as communication, and really have gone quite deep into supportive care. And again, as I mentioned earlier, I'm really proud of you all to have kind of stuck with this, and really excited to see what's ahead. For this course, much of the information was adapted from an online course. So you've heard me say this many, many times. There is a free online module from the International Society of Nephrology under the Academy website, and it is a module on kidney supportive care as well as conservative kidney management. They've actually put up a few new modules since we started this course, this Project Echo course, the champions. So please do check it out. I will continue to include the link in the chat, and if you have had a chance to do the course, please do let me know your feedback on it. And I do want to give credit because some of the content from the session today was from that module, those modules as well. All right, so today we're going to be identifying and addressing ethical challenges in kidney supportive care, as well as understanding some legal aspects of advanced directives and decision-making We talked a little bit earlier in other modules about advanced directive and shared decision-making, but we'll continue with that today. And then really looking at how to maintain patient confidentiality and privacy, with the aim to become more competent in our practice as we navigate ethical and legal dilemmas in the context of our care that we provide patients. Okay, so let's start us off. So this is from an article that was written, or a retrospective study in 2020, just looking at ethical concerns in the care of patients with advanced kidney disease. And this was published in the Journal of General Internal Medicine, really looking at what is the situation. So with an increase in frailer patients, so patients that are older or have more complex health issues, who also have multiple comorbidities, ethical considerations have shifted on deciding when dialysis initiation is appropriate or when withdrawal of dialysis as indicated, as we have, as kind of a global community, have been able to identify that not every patient receives benefit from kidney replacement therapy. And this is something that is kind of continually up for debate. As we advance more and more in the treatment options that we have, as we get better at diagnosing and supporting and caring for patients, we do know that there are some patients that are frailer, or they are older, and they may have multiple health issues that are currently going on. And when these things come into play, when we consider holistic care for our patients, we as a global community have begun to acknowledge that not every patient will derive benefit from this type of replacement therapy or dialysis. And this kind of coincides with research and more data from 2019 and 2018. All the kind of references are there at the bottom, about older and sicker patients who develop kidney failure actually have poorer outcomes. So in the context of when dialysis was started, for patients that are over the age of 65, they had a 30% mortality within the first year. Those living in a nursing home, so this would be from countries where patients are living in community living, where they have long-term care facilities, up to 58% had a mortality within the first year. And then also patients, while in hospital over the age of 65, had a 62% of mortality in the first year. And this is something that we may not have strong data in our kind of working countries where we currently are based, yet we know that this is actually pretty similar to our situation. Our patients sometimes have high symptom burden. They have high rates of dying in the ICU or hospital. They have high rates of intensive procedure during the last month of life, and are least likely to receive palliative and hospice services when compared to patients with cancer or dementia. And we at AHN are trying to change this narrative. Of course, we are, and we're honored to be part of the supportive care team, but we are trying to support patients and make sure that last line there is that our patients will have more likelihood of having access to palliative and supportive care services. But as we get into this topic today, I do want to kind of take a quick step back as we think about ethics. So as we think about patients that are getting older, that may have more comorbidities, that are more likely to die within the first year of dialysis initiation, how do we go about supporting them in an ethical way? What is medical ethics? Well, medical ethics, you probably remember from your undergraduate or your training courses, is a system of moral principles or rules of behavior. And it's kind of a way of life or a pattern of conduct, the way in which people choose why to act in a certain way. And there's four kind of main ethical principles that we usually focus on related to medical ethics. The first one, or you probably are familiar with all of these. This was shared or published in an article more recently from just general medical ethics, but really focusing on kidney disease. So in 2008, Davison and Hawley published an article talking about the ethical issues in the care of vulnerable chronic kidney disease patients, and really looking at these four kind of aspects. So you're probably familiar with these, but as we shift these towards our dialysis patients, we really want to consider the following. So beneficence. This is when it consists with the principles of beneficence and non-maleficence, in which dialysis should only be provided when it's clinically appropriate. And this is really important. As we continue to think about our patients, we want to make sure we're providing the best situation for our patients. And we want to make sure that dialysis, again, isn't going to harm our patients. So if we think about doing the best and causing no harm, this is what we think about when we think of beneficence and non-maleficence. In terms of autonomy, we think of this as consistent with the principle that dialysis should only be given when a patient is able to determine independently the decision to have or not to have dialysis. And we can add in our context the patient and their family. We know that in our context here in East Africa, our families are huge when it comes to decision making. And we need to make sure that it is the patient and the family having the ability to make the decision to have or not to have dialysis. When we think about justice, it is the provision of potentially futile interventions that impose cost and sometimes even undermine the efforts to provide necessary healthcare to all patients. We need to think about, especially in situations where we have limited resources, how do we provide justice in this situation? When governments are able to fund dialysis for at least some patients, respect for justice requires that efforts are made to promote equity in access to available resources. And we know at AHN, this is a big reason why we are really excited that in places like Kenya, Tanzania, and Rwanda, we are making it more equitable for our patients to access dialysis, because we are going to remote, kind of underserved regions to ensure that our patients have access to dialysis. And also to achieve equity in treatment when inequities of access is unavoidable. So fair and transparent criteria and procedures governing access must be established. So in AHN, I'm not so familiar, and this might be something that we will speak to those. Maybe Dr. Mazar can chime in once we're done the teaching for today. But how do we at AHN show transparent criteria to really identify patients have fair access to resources? Again, I know in most situations we offer dialysis. Justice goes a little bit further. So procedural justice requires that decisions about access to policies be made by legitimate authorities who are accountable to those affected by decisions. So for example, such decision-making should be transparent, informed by evidence, ethical principles, and consistent in the application of these principles or these rules. So when we think about dialysis, it is also that we need to consider procedural justice. And then as we go even further into distributive justice, this really requires the development of frameworks to guide the allocation of these limited resources that we have. So for example, guidelines related to determining people's eligibility to access dialysis or to even access funding for dialysis. And these are all things that can be quite complicated and quite complex. And this is why I want to shift now the conversation, and I'd love for some participation in the chat as we begin to think about as a group, if you could share or describe an ethical issue or dilemma that you've faced as you've provided healthcare to patients with kidney failure. So I want you to think of a situation where you eat of these autonomy related to making decisions, beneficence, so doing good, and then also not doing harm. Have you ever faced these kinds of situations in your work? We had a really good discussion during our fireside chat related to ethical dilemmas, and Dr. Esther brought in some really excellent cases about reflecting on the type of care that we give and how do we kind of solve these kinds of issues. So I'm curious to hear if anyone has an issue or a dilemma that they regularly face, or a quick case that they would be interested to share. Yeah, this is true, Dr. Zale. Sometimes we face dilemmas when a patient isn't able to decide for themselves. So it could be for a variety of reasons. Maybe they're too sick, they can't decide. Sometimes they're not really understanding the complexity of the health situation, so they rely on their family. Maybe our patients could potentially be illiterate, or we don't, have a good way of language. There sometimes can be dilemmas as we rely very heavily on family members. Yeah, sometimes we as a team can have a dilemma when we've had young patients that have the manpower of the family, but they can't fund it. So for sure, we know that our funding sources are different in different places where we work. And this is definitely a dilemma. What do we do when we are facing patients who don't have the financial or socioeconomic ability to really pay for their insurance or pay for the care that they need? How are we providing dialysis in a way that is just when the resources have to be paid for sure? Oprah and I were interacting a few weeks ago related to a patient who was in ICU and was quite elderly, was in a coma, so was not responding verbally. And the medical team had asked if she could kind of counsel the family into making a decision about dialysis. And it was quite an ethical dilemma to really know how to share difficult news with the family, to help them make a decision that was the right decision for their loved one. And it was really complicated. It was very complex. Patient was at the end of life, yet the medical team was wanting to continue to support potentially starting dialysis kind of at such a late stage. And I know that was very difficult for Oprah and her team. Yeah, and Francis, you're right. Some families need information about the patient, but the patient doesn't want to share information with the family. That's very true. There can be times where it's something that we call collusion, where somebody is wanting to hide information, either the patient hiding from the family or the family hiding from the patient at times. And this can really be causing us as healthcare providers to have an ethical dilemma when we can't openly talk to our patient, or we can't openly talk to our families about the care that their loved ones are receiving. It can really, we can face a lot of dilemmas for sure. Azale had a patient a couple of months ago in the 30s with kidney failure and end-stage renal disease, where the family refused to start dialysis as they were unsure if they would be able to continue. So lots of questions here. So a very young patient with severe chronic illness, not wanting to start dialysis, in which dialysis may have been able to prolong the patient's life, but kind of looking long-term, not sure if they were able to sustain a level of ongoing treatment. So really super complicated. How do we help patients and their families make these kinds of decisions? And Sifa's sharing, and I see Oprah saying that, yes, it was definitely a dilemma when breaking bad news, for sure. Sifa's sharing, when our patients consume food that's restricted because they're harmful, yep, the dilemma definitely comes when the patient sees that he or she can decide it's their own body that is being harmed. It's like we do beneficence while violating their autonomy, for sure. So sometimes when we have a variety of ethical kind of concepts in play, sometimes we can have it where there's conflicting kind of issues and values. We're trying to do no harm. We don't want our patients to harm themselves, yet we also want them to be able to make their own decisions and kind of live the life that they want to live, and really kind of supporting them with the best possible evidence we know. And oftentimes that requires them to have a fairly restricted diet. We want to do good for our patients by really encouraging and supporting them to make good decisions related to their food and their diet. Yet do we do that at an expense of their kind of independence or their autonomy to kind of make their own decisions about how they live their life? For sure, very complex. And I know Even, for example, we talk a lot about patients being non-adherent to dialysis treatments. Again, we want to do good. We don't want our patients to harm themselves. We want them to be regularly attending their dialysis sessions. Yet if a patient kind of has thought through everything and they kind of independently say, like, I don't want to keep coming to dialysis, continuing to support them in their independence and their autonomy to make decisions is also really important. It's kind of like weighing that scale. And sometimes it is very difficult to know how to support our patients in that situation. Thanks for engaging on the chat. That was great. And those were all very good examples of how we deal on a regular basis with ethical issues in our work. There's a few other examples I want to bring to the group. And this is related to how we provide support and care to our patients, especially related to confidentiality, decision-making, as well as information giving. We talked about this a little bit previously, but even withdrawing or withholding treatment, advanced care planning, and even end of life. So as we think about this, how we support our patients making decisions to initiate, maintain, or pursue non-dialysis treatment, sometimes there's challenges and barriers to these issues. So in our situation, if there's inadequate understanding of ethical or legal requirements around consent or initiating or starting dialysis, we can sometimes have challenges. And we know that many times our patients start on dialysis and they're not necessarily feeling well. They may not be as informed as we anticipated they were because they were overwhelmed. They were in the hospital. They could even have been started off in the ICU. And this informed aspect or understanding of informed consent can be quite complicated. It's also difficult for us as healthcare providers when we don't have access to good training or models to have conversations. It's actually quite a barrier. We can't provide good care with our patients as they kind of make decisions to start dialysis or maintain their dialysis if we're not prepared for these. I know that's something that Oprah and I talked about a lot 2 weeks ago, where she was feeling very overwhelmed by the situation that was in front of her. And we were able to get some more experienced providers, not necessarily in kidney failure support, but just having difficult conversations, breaking bad news. And sometimes a barrier for us to really support our patients is actually we don't have the training or the experience in that. We also see that we as frontline providers sometimes even have discomfort with having these kinds of conversations, so then we avoid it. And then definitely a perception that understanding a patient's prognosis sometimes is insufficient. So we then don't have a clear recommendation of how to support a patient on this. What can we do though? So if we are faced with situations where there's challenges and there's barriers, we want to be fairly systematic. So in 2017, in the Lancet, a team published kind of ethical issues related to dialysis therapy. And it's a very good article. So I'll also share this resource with you all so you can kind of review it in your own time. But they really focused on very specific ways that we can support our patients and our families while we make kind of these decisions with them. So we want to promote our patients' best interests when we are considering these situations. We want to increase access to dialysis, which is a big part of AHN's mission and vision. And we do this while maintaining procedural and distributive justice. So again, we want to ensure that anybody who needs access to dialysis has access to dialysis. And of course, in Kenya, we're very fortunate because we are able to provide dialysis through publicly funded insurance reimbursements, which is great. And that really shows kind of our ability to have dialysis not just for people who have private insurance or people who are able to afford high kind of expenses related to their healthcare. We also want to minimize or influence the financial incentives or competing interests. So again, offering our services through publicly funded sources is really key for us providing equitable treatment to all of people kind of in our area that need dialysis. We also want to ensure the quality of care in our service delivery and also access to the non-dialytic supportive care. So this is an area where we at AHN, I think generally in our region, where we're not doing as well related to offering supportive care or palliative care currently to patients that are not on dialysis. So supportive care at AHN, we're trying to integrate it into all of our staff. Of course, it's going to take quite a long time for us to really see major changes in the way that we at AHN kind of deliver care over the whole organization related to supportive care. But we know that access to palliative and supportive care is limited in our settings. So we obviously understand and know that our patients' access to palliative care is limited. We also want to minimize the financial burden on our patients and the healthcare systems. And AHN is really doing this well in the sense that we offer some extra services to patients, not at an extra cost. So the nutrition program, as well as the supportive care program, are these kind of extra services that we're adding to ensure that the care that we're giving is holistic. And then the last one is something that we haven't been focusing on fully at AHN, but really protecting the interests of vulnerable groups, especially during a crisis situation. So really understanding how to provide holistic care to patients, even in crisis situations. So in refugee camps or in natural disasters, it can be very difficult to offer and continue to offer dialysis treatment. But this is something that we do need to take or consider as we think about kind of all the different regions where we're working. So we're going to ask a few questions. So what are some questions to think about as we provide ethically clinical care and really support our patients and families as they make decisions? So these are kind of rhetorical questions that you can kind of think in the back of your mind. And I can add this to the chat as well as the WhatsApp group afterwards. But how can we, as a group, enable patients or their surrogate or their other decision maker to be informed and voluntary and really support kind of decisions on treatment related to end-stage kidney disease? And then the next one is, when is dialysis in the best interest of our patient? And I think this second question really, I saw Oprah and her team really taking to heart when they were faced with a situation that was very complex, really thinking about, is dialysis, is this mode of treatment and care that in the best interest of the patient? Or will the patient receive more suffering and more difficulties and more challenges with the initiation of dialysis? And those are not easy questions to ask. We often in healthcare are definitely pro-care, pro-treatment, prolonging life. And I think that this, again, with the support of your colleagues and us on the supportive care team, are really here to really help you kind of delve into these kinds of questions. So we're going to shift quickly now to confidentiality. So some, again, kind of rhetorical questions to think to yourself. How and when do we share patient information? We won't do this one in the chat because we have a few rhetorical questions that I'm going to be putting out to everyone. But I want you to think about this, the concept of confidentiality, where we try to support patients in a way that wouldn't breach any confidentiality, where we share information kind of in a safe way, really providing privacy for our patients. How do we do this? How and when do we share patient information? How do we assess patients? And when is the family involved? So we need to make sure as we provide this type of care to our patients that all our staff maintain confidentiality related to patient information. So it's very important that we do not share direct patient information. We keep any information, we do not keep information on any of our personal devices. And then we make sure that we don't take medical records out of the clinic. Of course, it gets a little bit complex when we use digital medical records, and we need to be very careful, especially as we become more digital, that we are ensuring confidentiality and privacy of our patients. As we think of decision-making, we think of that independence and that autonomy of our patients. And we also think of that our patients should be able to and be supported in making decisions for themselves alongside their families related to their treatment options. So we know that every patient and every family is different. Everyone has different values on how they go about making these kinds of decisions. And we as a team need to kind of come alongside and really support informed decision-making in that shared decision. These discussions should include the physical as well as the psychological and socioeconomic kind of situation for each choice. So whether a patient is starting dialysis, how are they going to be affected physically, psychologically, socially? And then definitely ensuring that patients and families have time to reflect on their options and also for them to be able to ask questions. When we think of information, we do need to think about how much information do we give to patients. Our patients have the right to information related to their diagnosis, their prognosis, and even their treatment outcomes. And this is very important. Again, we mentioned a lot of our patients start dialysis and they're not feeling well. So we need to continue to find ways to share information regularly throughout their illness. A review of qualitative research reported that some patients have not enough choice related to their dialysis treatment. And this was in the same article that was released in 2017 related to ethical issues. And it really showed the factors that undermine a patient's quality to make decisions was due to their lack of information about their options, the timing and expected benefits of their dialysis. They saw that they also didn't have enough time to make these decisions. Many patients had resource constraints. Sometimes their patients were influenced potentially in not a positive way by their peers and their family, and also were affected by deviating from the status quo. We've talked about it quite a bit, but there are several frameworks to support patients in their decision related to their serious illness. So we've talked about the SPIKES protocol of how to support patients. We've done the Serious Illness Conversation Guide. And these are really to really assess a patient's knowledge, teach them about any alternatives they have access to, really understanding their values, and then discussing our patients' beliefs and their choices. And a big part is recording and documenting. So this is an example of the Serious Illness Conversation Guide. I think that we did this several weeks ago in our communication session, but this is a really good review. So I can share this and you can kind of review this as you go forward. We do need to think about cultural and spiritual considerations, especially related to any rituals or meanings associated with illness of our patients, and support them in their beliefs and values. We can't talk necessarily about ethics if we don't really know what the values are of our patients. And we know that oftentimes when it comes to spirituality, supporting our patients as they search for meaning in their life, in their illness, and in the stage that they're currently at is very important. Education programs for patients and decision makers are very valuable as they really seek to improve patient literacy and empower them to make decisions. And I know at AHN, with the recent team that came from Harvard Business School, as well as some of my work in the future, we'll be really looking at how do we improve patients' understanding, especially related to their care and supportive care. So it is very important as we think about ethics and we think about kind of supporting patients, that all of our work be grounded in kind of this human right to health, in which we focus on promoting equity, we provide the best possible care possible, we prevent harm, and really encourage our patients to make decisions about their own care. As we think, just for the last few minutes, and then I'd love to have a discussion and any questions about ethics, is really thinking about legal compliance. So in each facility that we at AHM partner with, they have different kind of legal policies, especially when it comes to advanced care planning. And we talked about this before. A lot of our partners will have different policies related to advanced directives and do not resuscitate orders. It can get complicated in each country based on national laws as well. So currently in Kenya, we don't have kind of a legal framework to kind of back up do not resuscitate orders and do not intubate orders, which makes it complicated as we support patients kind of planning ahead. Each hospital or facility in Kenya is responsible for this. So we need to ensure that with each partner, with each clinic, we really understand and know what does the partner facility do as they support their patients. And really understanding what is the system that we're currently working in related to legal compliance on this. And I think that's something that we've kind of touched on earlier in the modules and in the course. So we'll take a little bit of time for questions. Let me put a few of those resources in the chat. Yeah, and then we'll be nearly finished. So we can take it for questions or comments if you wanted to put that in the chat. I see Francis has another comment earlier related to ethical dilemmas that facing when insurance patients want to test all investigations, but insurance doesn't cover that. And then the patient also refuses to pay. It can be very complicated. You're right, to know how to support patients in those kinds of situations. So when we don't want to harm patients, yet our hands are sometimes tied related to the resources if they're not willing to pay. Dr. Mazar, do you know, I know that you were also on the ethical discussion with Dr. Nafula. Any thoughts?
Thank you, Erin. Ethics and confidentiality is something that you feel very important in all aspects of the medical field, and especially in our setting, because most of our patients are outpatients, so they usually are fairly stable, and it complicates matters in that way, because then these are independent people. And when the caregivers come through and they want to know exactly what's going on with them, the patients have that right, their autonomy is there, that, I don't want you to tell my family X, Y, and Z because they're going to get worried. Whereas the family want to kind of know where the patient is so that they can plan further. So you, as the caregiver, from the medical side, are usually torn apart in between these two, aspects. And it's usually very difficult to handle this. But I feel that it is it is a skill that one develops as one experiences these problems frequently. And you learn the skill to try and not negotiate your way around it, but rather have it approach it in such a way that you do not breach that ethical practice that you have been sworn to protect. So it is not as easy as I make it sound. It is fairly difficult, but it is something that we need to learn and keep in practice most of the time. And I believe that the sessions we had with Dr. Nafula and the ones that we had with you today kind of just cements the whole process. And I feel that we should be revisiting these sessions now and then again to try and just fine-tune our approaches to our patients.
Yeah, I know that there are some situations where people can bring cases to an ethics committee. And I know at AHM we don't have the same responsibility related to intensive care units and kind of ongoing treatment because, like you're saying, we're outpatient focused. Yet I do wonder if that would support some of our staff, and maybe an informal committee, or maybe it already exists. I don't know at AHN. But there can be times where it can be very distressing to frontline staff to know how to support, and I think that's when teamwork comes into play. Dr. Azel, do you know if we have an ethics committee at AHN?
It's not really.
Yeah.
No, I understand we wanted to create one months ago with Dr. Roy. We had a discussion on, but that was on research ethical committee, was not particularly for these patients. I'm not sure if we have any currently.
It would be interesting to see now that our champion kind of program is coming to a close, kind of where some of our champions want to focus kind of efforts going forward. I know that there's one of the teams in Nairobi was wanting to really look at bereavement support. If anyone in this group is interested in kind of moving forward with some kind of ethical maybe making a small group, really focusing on some common ethical concerns that our patients and families have, that would be also really interesting, I think. The thing sometimes with ethical dilemmas also is they're kind of, sometimes we need to make decisions very quickly. And I know this is one thing that was mentioned during the lecture today, but sometimes we do have more time. And I think what can be a little bit awkward is we are human as well, and we know that making difficult decisions can take a toll. So sometimes we avoid kind of helping our patients make these decisions because it takes time, it's emotional, and it can be draining. And I know that's something that we should probably kind of keep at the forefront more often, finding ways to help each other in making these decisions.
To our settings, we feel that challenging dilemma. Sometimes you need to make a decisions, but you fear maybe the ethical issues, considerations, also the law of the country. You can face it. So it gives us a challenge at the moment to make a decision for some areas. So I think the communication to the beginning from the service till you start with the patients up to the end, you reach the decision maybe to start dialysis. I think the key issue is communication between the patients and relatives and the caregivers. If we have a good communication on between, we can reach the decisions easily with.
Yeah, I think you're right, Francis. As we focus on communication and really providing that holistic support, understanding our patients, understanding their beliefs, their values, I think you are right. I think we can support them in making those decisions. It requires effort. We have to know our patients well. We have to obviously make sure they have enough information that they can make a good decision. And then really supporting them in that decision. I think at times we can, as healthcare workers, think that we know more than our patients about a situation. And I think also coming in with humility and being very humble as we provide care. And then as they make a decision and as we kind of support them in that, really kind of going along with what they believe is the best decision for them. Okay, so Oprah was saying she's going to join cohort 2. So actually, this is a good segue into how we'll kind of end this course. I feel like today is a bit anticlimactic. We need to put on some music or something for you guys as we finish today. But we are finished. So I have been able to teach the 12 modules. Dr. Azael, Dr. Mazar, and myself, along with most of you, have attended as many as you were able to. We are really excited. So we have all the recordings. I'll probably meet with Dr. Azael to figure out how to get them online. I know the Dropbox is a little bit, it's large, so sometimes it's hard to get that, but we may make kind of like a private group on YouTube for this program. And we would really love if you as champions could consider kind of catching up, because we would like to give a completion certificate to as many of you as possible. We are checking attendance. So over the next few weeks, you'll kind of see, and I will let you know which sessions you need to catch up on. And then hopefully by the end of June, beginning of July, we'll be able to issue out the certificates. And quite excited to see where things go. I've been with AHN for about 6 months now, and we in Kenya are in the process of hiring 2 Kenyan palliative care nurses to really support kind of clinical visits and clinical work, which is great. And really looking for ways to bring you champions kind of on board as we go forward. So please kind of be aware, and I'll keep communicating on the WhatsApp group, kind of what the next steps are. But if you can plan to review any recordings from a YouTube channel that we kind of get created, it'll be easier for you to review them. And yeah, over the next 2 to 3 weeks, if you can catch up on as many as possible, I'll get you an attendance list, hopefully by the end of this week. So you can kind of see which areas that you need to catch up on. And then we'll plan to move forward. There's some new things related to documentation that we're hoping to implement. And I know once we get our palliative care nurses here in Kenya on board, we're going to be doing kind of direct supportive care visits. So in the other countries where we won't have the palliative care nurses directly implementing, I'm happy to work with and support some of the new kind of implementation kind of as needed. But yeah, it's been a great pleasure to meet you. I know I had a chance to meet in person a lot of people living in Kenya because I obviously am also based here. So I apologize to everyone in Tanzania and Rwanda. Thanks, everyone.